Hello, thank you for joining the Health Effects Institute 2020 webinar series. We hope all of you are safe and healthy during this challenging time. My name is Annemoon van Arp. I'm Acting Director of Science at HEI. I would like to acknowledge Hannah Bogart, Principal Scientist at HEI, who co-organized today's session. As you may know, we are holding 5 webinars in lieu of the HEI annual conference that was planned in Boston this week, but had to be canceled due to the coronavirus pandemic. We are very grateful that the session speakers and chairs have agreed to give webinars instead. We would also like to acknowledge the hard work of our staff who worked behind the scenes to transform the annual conference into a webinar series. In particular, Pallavi Pant, Eliane van Vliet, Robert Shavers, and Joanna Kiel. Today's session chairs are Jennifer Peel, Professor of Epidemiology at Colorado State School of Public Health and Department of Environmental and Radiological Health Sciences at Colorado State University, and Kiros Berhani, Cynthia and Robert Citron, Rosalind and Leslie Goldstein, Professor and Chair of Biostatistics at the Mailman School of Public Health at Columbia University. They're both members of HEI's review committee. Before we delve into today's webinar, I'd like to make a few housekeeping announcements. We'll hold all questions until the question and answer period at the end. Questions should be submitted via the Zoom Q&A function. You can add and upvote questions to the Q&A section at any time during the webinar. If you have any logistical questions, please let us know via the chat box. You can also email us at jkeel@healtheffects.org. This session will be recorded and will be available on YouTube in the next few weeks. You will receive an email with a quick survey afterwards. We appreciate your feedback. Finally, registration for the next webinars will be posted soon. Today, we're kicking off the series with the webinar, The Big Deal about Big Data, Causal Inference, and Accountability Research. Today, we will take a close look at accountability research, which evaluates the effectiveness of air quality interventions in improving public health. We will discuss the role of big data, how accountability research can contribute to evidence for a causal association, and approaches to synthesis of the evidence. We have a really great lineup of speakers for you today. I will now hand over the mic to Dr. Jennifer Peel, who will introduce the first speaker.
Hello, thank you, Annemoon, and welcome everyone. Our first speaker is Dr. Doug Dockery. Doug is an emeritus professor of environmental epidemiology at the Harvard School of Public Health with a distinguished career in air pollution epidemiology. Some of his most recent research evaluated the effectiveness of environmental controls in improving health, including evaluations of the effect of coal bans on mortality in Ireland, effects of reduced fine particle concentrations on life expectancy in the United States, and the effect of workplace smoking bans on myocardial infarctions in adults and asthma in children. So I will turn it over to Doug with a reminder for everyone else to mute their mics, please.
Thanks, Jennifer. Let's see. Is my screen showing now?
Yes.
Yes.
Okay, good. Okay, so accountability. What is accountability? Let's see. For us academics, we often ask the question, what is the relationship between exposure to pollution and health outcomes? So this is the traditional epidemiologic view. But for the policymaker, they're asking a very different question. What is the relationship between a regulatory action and health? And for that, we need to start looking backwards to ambient air quality changes in emissions, and ultimately to that regulatory or other action. And this is what we call accountability studies. And in 2003, the HEI organized a meeting which came up with this paradigm, the chain of accountability, to pull this all together. And it provides a nice framework for us to think about these studies and how they all fit together. Now, over the past 2 decades, there have been quite a few studies on accountability. and in fact, leading to a whole series of reviews of this area of literature. And it's not my intention to review the literature in total here, but rather to think about what this means in terms of empirical designs and what we've learned and how we go forward with this. And specifically, we think about randomized controlled trials as our gold standard for causal associations in observational studies. But we also have data from quasi-experimental studies, that is where we have natural experiments. We have policy evaluations where we look at policy implementation and subsequent changes in health status. And more recently, this development of methods to randomize post hoc observational studies using big data. So I want to talk about all of these. And specifically, if we start with randomized controls trials as our standard, the concept is we would take a group of individuals and then the investigator would randomize those into those who would receive the cleanup, the intervention, and those who would receive no cleanup and no intervention. And the concept here is that if we randomize, then we would have two comparable groups to work with. And we follow those people up, monitoring their health status, and ultimately compare the results of those two within those two groups, which are theoretically comparable. Generally, this is not feasible for environmental studies and actually usually not ethical, but we do have some examples where this has been applied, most specifically in the case of interventions to provide families with improved fires for cooking. So in a randomized controlled trial in Guatemala led by Kirk Smith and colleagues, they randomly assigned families to receive an improved stove with a chimney to remove the smoke from the home, the kitchen, and followed up the children in both of these groups with weekly visits by a nurse and follow up with a physician to diagnose any respiratory illnesses. And the study was remarkably effective in reducing PM 2.5 concentrations to these extraordinarily high values in the control homes to reasonable levels in the intervention homes, a reduction of 96%. And in fact, the rates of physician diagnosis pneumonia decreased from 63 per 100 child years to 50 with the intervention. So this was very positive. But on the other hand, when you look at the reduction in the exposures of 96% versus only a 20% reduction in the health outcome, it was somewhat disappointing that we did not see a more substantial effect. And what was the reason for this? It's illustrated here in this picture from my colleague John McCracken, and showed that really what happened was, although the kitchen PM levels dropped by 20-fold, the actual exposure of the children only decreased by about 2-fold because kids don't spend their entire day in the kitchen. And in fact, the chimneys were simply taking the smoke from the indoors and putting it outdoors where it was still a community hazard. And children were spending their time indoors as well as outdoors. So when we think about this in terms of the accountability chain, the intervention was very effective in reducing emissions, reducing kitchen PM 2.5 concentrations, but actually less effective in reducing the exposures of these children and less effective in reducing the overall health burden on these kids. So there have been substantial lessons learned from this, and improved designs for stove replacement studies have been undertaken. And I think Jill Baumgartner is going to talk about that somewhat in her next talk. What about natural experiments, these quasi-experimental designs? Here we would have a pre-intervention observation period, and then there would be some intervention of some type leading to a cleanup, and then when that ultimately there is a reverting back to the original conditions. And so examining the health status of populations in these 3 different time periods provides some indication of potential benefits. So the classic example here is in Utah Valley, where a steel mill in this high altitude valley was producing a lot of air pollution during winter inversions. And between July 1986 and August of 1987, the workers went on strike, closing the steel mill, but this led to very substantial improvements in the air quality during the strike compared to the winter before and the winter after the strike. And Arden Polk examined the rates of admissions for children to the local hospitals and showed that those admissions dropped very dramatically during this time period also, providing very visually compelling evidence that there was an association here between improved air quality and reduced respiratory problems, respiratory admissions for children in the community. So the intervention here, the strike, in fact, led to very clear evidence of improved air quality and also very suggestive evidence of improved health in the population. On the other hand, there were other things going on at the same time. Clearly, there were economic effects in the community, potentially loss of medical insurance of the workers, lost population, and so forth, which might be alternative explanations for the change in the health status, not for changes in the ambient air quality. So this is a clear example of what we would consider to be confounders in a traditional epidemiologic study. For these intervention studies, for the accountability studies, we would call these changes in the counterfactual, in that, do we really know what would have happened? Is this really investigating the effect of the strike or other things through air quality, or is it through other things that might be changing in the population? Another example would be the 1996 Atlanta Olympic Games, where there were interventions in terms of trying to reduce traffic within the city of Atlanta during the Olympics. And Friedman and colleagues examined this, examined traffic counts during the games, changes in air pollution, and ultimately asthma emergency department visit. And what they found was that morning peak traffic indeed dropped by about 23%. They found evidence that air pollution declined in the Olympic period compared to the weeks before and after the Olympics, most notably for ozone, but also for other pollutants. And they found evidence that the rates of asthma emissions from various sources were lower during the Olympics than in the comparison periods before and afterwards. And this was true on a variety of sources. So it suggested that there were some benefits here in terms of improved air quality and also improved health of the population. Jennifer Peel, our chairman, followed up with an extended analysis of these data, looking at similar outcomes, although looking at emergency department visits. They also found that ozone levels dropped during the Olympic period compared to the period before and after, and also compared to the same weeks in the years before and after the Olympics. They also found that pediatric upper respiratory infections declined during the Olympic period compared to the periods before and afterwards, and also compared to the same weeks before in years before and afterwards. But what they did also observe is, although ozone levels dropped in Atlanta during this period, they had also dropped in all over the Southeast United States, as shown by data here from Augusta, Columbus, and Savannah. So this was not strictly a effect of the traffic ban, traffic interventions, but was a regional phenomena. And so, in fact, was breaking this chain between admissions and air quality and suggesting that the observed effects really could not be tied directly back to the traffic interventions. So more broadly, we've seen a lot of policy interventions put in place, and the question we want to address is whether we can actually detect these benefits. So for example, as Jennifer mentioned, we looked at the effect of the ban on coal burning in Dublin. During the 80s, there were very high levels of black smoke pollution in Dublin associated with burning of coal for domestic heating. And on September 1st of 1980, the government banned the sale of coal within the city of Dublin. And this had a very dramatic and immediate effect on black smoke concentrations over in that winter and succeeding winters. And the question was, does this lead to any improvements in health? We looked at mortality over the same time period, and you can see the seasonal trends and the high levels, especially in the wintertime. And after the ban, it looks like there has been a decrease in mortality in Dublin. So the question is, what is the counterfactual here? Do we look simply at the mean numbers of mean death rate before the ban and extend that to the post-ban period? And if that's the case, then it looks like there's very clear evidence that mortality rates have gone down. But many other things have been happening in this same time period in terms of delivery of healthcare, behavioral factors, and the economy and so forth. And the question is, what would we use as a counterfactual in this case? And so we looked to other counties in Ireland which were not affected by the ban to see whether they had similar effects. And if we plot the rates of mortality in other counties, unaffected counties in the middle of the country, overlaid on the top of what we see in Dublin, it becomes apparent that there was this overall long-term trend across the whole country that was independent of the effects in Dublin. And in fact, we really could not separate the effect of the ban on coal sales from the long-term trends, the long-term improvement in health in the population. So although very clearly there was an effect of the ban on coal sales on air quality, we could not make this leap, this connection to the human health effects, at least measured by the mortality rates. Because we have this question of what is the counterfactual, what are the demographic trends, the healthcare trends, the behavioral factors, as well as the other climatic and seasonal infections and so forth that might be influencing this. So the question is, how do we develop a counterfactual in evaluating these effects? So Ted Russell undertook this looking again at the city of Atlanta and evaluating the effects of various power plant and mobile source controls that had been put in place in the Southeast between 1999 and 2013, estimated the emission reductions based on actual emissions and the actual implementation that went on in this period, calculated then the daily air pollution from the emissions meteorology that would have been expected if these control strategies had not been put in place. And so was able to compare what was actually observed over time with what would have been expected if the controls had not been put in place. And then estimated the daily emergency room visits based on time series of these data, and then applied that to the counterfactual estimated air pollution concentrations. And finally, differenced the observed respiratory and cardiovascular emergency department visits compared to what was expected from the counterfactual, and developed these estimates of how many respiratory and cardiovascular emergency departments were avoided as a result of these interventions. So this shows the what could be done with this, but it also shows how difficult these types of approaches are. And, you know, really illustrates one of the beauties of many of the other studies where you have a very clear intervention and clear outcome. Here, it's actually a lot of modeling, and it makes it, it's a very, very challenging approach to take. An alternative might be to think about, well, are there intervention communities that we could look at? And to think about, well, are there other communities where there was no intervention? And so to try and provide this direct comparison between different communities with and without interventions over the same time period. And this is what Arden Pope and Majid Azadi and I attempted to do in an analysis of life expectancy across the United States. We identified 51 metropolitan areas across the United States where we found data for PM2 concentrations going back to 1990 and matched with concentrations measured in 2000, spread all across the United States. And if you look at life expectancy in around 1980 in those communities versus the PM2.5 that was measured at that same time for these 250 counties or the 50 metropolitan areas, you can see the suggestion that as air quality, as PM2.5 went up, life expectancy went down. So we have a cross-sectional association. Most of these communities were above the standard that was subsequently set in 1997. If we jump ahead 20 years now to 2000, what's happened is that air pollution has dropped. Many of these communities are now in compliance, but life expectancy has also gone up. But interestingly, you still see this cross-sectionally, this association suggesting that as air pollution goes up, life expectancy was down even in 2000. And if we take the difference in life expectancy and compare that to the change in PM2.5 concentrations as shown here for each of those communities, this difference in difference analysis, then we see that in the communities with the biggest reduction in PM2.5, we saw the suggestion of larger reductions in life expectancy than in the communities with small or effectively no change in air quality. There was less increase in life expectancy. And overall, there was about a 6.6 year increase in life expectancy associated with each 10 micrograms per cubic meter of PM2.5. So in this case, we're not looking back at any specific regulatory action, but the net effect of multiple regulations over this 20-year time period. We did observe a mean decrease of 6.5 micrograms per cubic meter in the PM2.5, and overall about a 0.4 year increase in life expectancy associated with this. But again, the question is, what about other behavioral, contextual, demographic changes that might be affecting human health response here? And what we were trying to do was examine different communities, assuming that these factors would all be operating similarly, but it's not entirely satisfactory. Alternatively, if we think about the whole population, large populations, and the concept we were trying to develop is that within the population, there are people who are going to be experiencing an intervention and other groups of people who would be not experiencing this intervention. And so is it feasible to think about selecting groups within this some of these people who are matched in terms of the same characteristics? So the job of the investigator is trying to match these populations with the intervention and those without the intervention with matching those with similar characteristics of age, sex, race, smoking histories, body mass index, history of chronic obstructive pulmonary disease, obesity, whatever, as you think about a large number of predictors or potential confounders here. And with a large enough population, you would think it would be possible to match people in the intervention group with someone in the non-intervention group. And if you could develop these groups, then follow them up and compare the results. And so this is like a randomized controlled trial in that you've now you have different interventions, but now you've matched these people to reduce the confounding or other covariates. So this becomes an analog of the randomized trial. So Corey Ziegler and Francesca Dominici attempted to do this, looking at the impact of National Ambient Air Quality non-attainment designations on health in the population. They identified 800, almost 900 PM monitors in 2005 in the eastern United States, and classified these into those that had attainment, were in attainment of the standard, the PM 2.5 standard, and about almost 300 that were in non-attainment. So being designated as non-attainment means that they have to take various actions to try and come into compliance. So theoretically, there would be an intervention associated with that. And then they matched those with 10.5 million Medicare beneficiaries who lived close to those monitors. So they lived within 6 miles of one of these monitors. So here they've identified groups that are potentially in an intervention, that is a attainment area, or non-attainment area versus a non-attainment area, the controls. So the concept is that the intervention there is this non-attainment designation in 2005, and matched groups of Medicare beneficiaries living within 6 miles of these attainment or non-attainment PM 2.5 monitors to predict the PM 2.5 that would have been if there had been not this designation, and then to predict the mortality if this designation had not occurred based on the Medicare, and compare that to the mortality based on the actual Medicare data. So with these 10.5 million beneficiaries living close to these monitors, you can divide those into those who were in the attainment area versus the non-attainment area. There were clear differences between these areas. I mean, as you would have expected, they were higher PM 2.5 concentrations in the non-attainment versus the attainment area. They also were more likely to be in non-attainment ozone areas. As we expected, the mortality rates were higher in the non-attainment area than the attainment area. The hospital admission rates for cardiovascular disease were higher, and for respiratory disease were higher. But these groups were also different in terms of being more urban, being more minority populations, having higher household income, difference in a large range of characteristics, which somehow we want to adjust for. And the way they approached this was developing a propensity score for each of these groups based on the PM 2.5 monitors and people living around those. And this is an aggregation of the probability in being in one of these non-attainment areas based on all these characteristics. And then matching these groups, identifying groups that had similar net propensity scores and matching those. And then you want to eliminate any of the areas where you cannot match them based on what those underlying characteristics are. So this shows the difference. These are all the characteristics that were evaluated for each of these attainment and non-attainment areas. And you can see that there were large differences for some of these parameters in the PM 2.5 and the urbanicity and so forth before matching. But after you match these and prune them down to the ones that have good matching, in fact, then you are able to remove the differences between these two groups and effectively attain a sample of the intervention, non-intervention, or non-attainment attainment areas, which are comparable. And when they did this, then they were able to match 183 non-attainment areas, that is the intervention group, with 221 attainment areas, 5.5 million Medicare beneficiaries. They were able to show that there was a small decrease in the PM 2.5, not statistically significant, but interesting that they could see this. And likewise, a small difference of 1.3 deaths per 1,000 rather, person years. Not quite statistically significant, but again, very suggestive that something was going on. So to me, this is important because this non-attainment designation is clearly a very weak intervention. You wouldn't expect much to be going on there. And we don't see much happening in terms of PM 2.5, but we do see some suggestion of benefits. It really suggested that there is improved air quality and reduced mortality associated with this. And really provides a model for an innovative approach for assessing national interventions, given the big data sets that we're talking about now that are becoming available. So, looking back on all this, we think of randomized controlled trials as a gold standard for causal associations. There are really practical limits to its application in air pollution, although there are some special cases where it is being applied. The quasi-experimental studies are really only effective for short-term effects and really depend on infrequent and unique interventions. The post-hoc analyses of policy evaluations look at the long-term effects, but the counterfactuals are very difficult to define in these analyses. And these randomization of observational studies, matching using big data, I think show a lot of potential for showing long-term benefits of large-scale interventions. So what are the lessons? I think these studies are asking the right question for policy assessment. The designs can be intuitive, and the beauty is they really are very accessible when they're done right and shown well. The modeling and statistics actually are not going to save us here. I don't think they're going to compensate for weak study designs. Defining the counterfactuals really remains very challenging and the biggest hurdle we have to deal with. Traditional randomized trials really have limited applicability in this field. And I think evaluating accountability studies based on the criteria for these clinical trials is really not going to be very helpful. And we've had some discussions about that in the literature. On the other hand, big data offers some real opportunities here. And I think we still need creative designs and potentially taking advantage of the big data with some of these new designs. So the road forward, I think there are some opportunities, and given where we are now, I think creative thinking might be able to lead us in new directions. So thank you, HEI, for your leadership in this and for organizing this workshop.
Thanks, Doug. As a reminder to all the attendees, please submit your questions via Zoom, and we will have a question and answer panel discussion at the end of the talks. So our next speaker is Dr. Jill Baumgardner. Dr. Baumgardner is an associate professor and William Dawson Scholar in the Institute for Health and Social Policy and the Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. She is also an associate member of the McGill School of Environment. She studies exposure to environmental pollutants and their effect on human health in the context of urbanization and development. She is currently conducting a study in China to evaluate the effectiveness of a coal ban and heat pump subsidy program in improving air quality. So I will turn it over to Jill.
Great, thank you, Jennifer, and hopefully you can hear me okay.
Yes, you sound great.
Perfect. I've been asked to talk about these topics in the context of settings where household biomass and coal stoves are important sources of air pollution, and including talking about some of the challenges of conducting research in these kinds of settings. So for people who are not familiar, household air pollution generally refers to pollution that comes from household biomass and coal stoves, also called solid fuel stoves, when they're used for basic household practices, cooking, heating. And it's a risk that largely affects poor communities. The highest proportion of homes are in sub-Saharan Africa and Asia. About 3 billion people use solid fuel stoves as their primary household cooking source. And it's important to just note that the estimates that are often shown for this, they don't account for secondary fuel use that are using solid fuel stoves for other purposes than cooking, which we know is really common. It's also any secondary fuel or secondary stove use. So it's likely underestimating global exposure to household air pollution. Incomplete combustion of biomass and coal emits lots of pollutants that have been shown to be bad for health. Carbon monoxide is the most commonly measured pollutant for decades, but studies over the past 10 years have largely shifted to measuring PM 2.5, given its importance for human health. I think a common misconception is that household air pollution is an exposure that's in this completely different range from outdoor particulate matter. And the data really tell a different story. So this figure shows the individual exposures to log transform PM 2.5 and carbon monoxide from a number of household air pollution studies that were conducted in 7 different countries. And this line shows the WHO guideline. And so we basically pooled all of these different studies. And then this red color indicates the range of yearly average outdoor PM 2.5 from the world's 500 most polluted cities. And so while most of these exposures to household air pollution are higher than the WHO guideline, and they are a lot higher than outdoor PM 2.5 in high-income countries, there's actually substantial overlap with outdoor PM 2.5 in some of the more polluted urban areas. Very few studies have looked at chemical analysis or source apportionment for household air pollution. This is a review that we did in 2017. So in this figure, the circles represent the proportion of PM 2.5 from household air pollution that was in a household air pollution study that was attributable to both different indoor and outdoor sources. So 2 of these are urban studies, but the majority of them are rural. Biomass and coal stoves are shown in red, so they're sort of the bright red circles that you see. And for all the limitations of source apportionment studies, these show that household stoves are certainly an important source contributor to indoor PM 2.5 and exposures, but they're not the only source or even the largest one. So sources like trash burning, traffic, and dust, they're also important sources of pollution in places where people are using these stoves. There's been decades of development to try and develop biomass stoves that are less polluting. This is showing emissions of PM 2.5 and carbon monoxide from different types of stoves. Most, but not all, are actually less polluting than an open fire, and none have really been as low polluting as gas-fueled stoves. So I think, at least in the health community, gas and electricity are increasingly viewed as really the most promising interventions for achieving large reductions in air pollution. But as you'll see in my presentation, a lot of the work has been done on biomass stoves to date. There's been really 2 directions that have been used in epidemiologic research to improve causal inference in household air pollution. The first was really focused on conducting observational studies with personal exposure measurement. And the idea would be that these would enable us to determine the pollution reductions that would be necessary to achieve a health benefit in these different settings. This is showing on the left-hand side the existing exposure response studies that have been done in settings of household air pollution. So there are a number of them, but it's obviously far fewer than the hundreds, if not thousands, that have been done for outdoor and urban air pollution. So overall, there's about 20 that have been done. The most commonly assessed outcomes were respiratory infections and blood pressure. So those are two examples of studies that were done on the right-hand side of the screen. I think a much larger number of studies have used stove type as an exposure metric. I'm not going to present on those here because of time. I think they certainly contribute to the evidence, but it's really hard to understand what stove type means for exposure in a lot of settings, given the variability that we see in emissions from different stove types that even have the same name. And it's often highly correlated with lots of confounders. So residual confounding has been an issue in a lot of those studies. The main challenge for exposure response studies has really been exposure assessment. It's hard. The air monitors that are used are expensive, they're bulky. Even the best ones don't have a battery life for longer than 48 hours. They tend not to be very robust to harsh field conditions. We'd actually, Health Canada had used a number of monitors for over a decade and was changing the type of monitor they were using. They donated them to us. And most of those monitors broke within the first 4 months of use in a high air pollution setting. Surrogate measures like indoor measurements, those have been found to pretty poorly correlate with exposure in a lot of settings. And the part of the problem is they still have the same logistical constraints. So you still have to deal with monitors and settings where there may or may not be electricity. And outdoor monitors fail to capture indoor sources. Biomarker research thus far has been really limited, in large part due to some of the cultural and logistical constraints in doing these measurements. So as a result, the policy for household air pollution has been largely driven by integrated exposure response models. These were developed by a number of people who are likely on this call, and they combine exposure response relationships from different sources. So looking at outdoor air pollution, secondhand smoking, and smoking studies, and then combined with household air pollution when those data were available. Notably, these models suggest that the curve is flattest in the exposure range that almost perfectly overlaps with the range that we observe in settings of household air pollution. So meaning that precision in exposure measurement, it matters even more than for outdoor pollution settings that we tend to see in high-income countries. So the second area of research that was pursued for causal inference was randomized controlled trials. So as Doug mentioned, the idea is that these would be free from confounding and would allow for measurement of the pure energy intervention effects. Trials are obviously quite expensive. They typically are just a few years in duration. So this often limits studies to acute outcomes, but that being said, the ones that have been evaluated have been really important for global health. So things like childhood pneumonia and birth outcomes. I just want to note that there's a massive ongoing effort to trial LPG stoves in a multi-country trial of over 3,000 homes. This has a number of outcomes, including severe pneumonia. The investigators for this study have gone to enormous logistical effort to try and implement measures that capture all parts of the accountability chain that Doug was presenting. So I think the investigators will be able to evaluate not only the total effect of the intervention, but also how it impacts health, which is quite important for understanding how these interventions actually work in the real world. Thus far, I think it's funny when putting together this slide, it actually looks worse than I had anticipated in putting it together. And hopefully I didn't miss any of these studies that did find an effect or a positive effect on an outcome. But these are the randomized trials of clean stove interventions that have been conducted to date. There's been 8 of them, and most of them have trialed improved biomass cook stoves. So most of them did not observe an effect of the stove on their primary trial outcomes, though a number of them did show benefits for secondary outcomes like blood pressure, neurocognitive impacts in children, severe pneumonia. So these are certainly important from a global health perspective. But I think overall the results of trials and many other intervention studies have been disappointing. So I don't have time to get into the details of all these trials, but I'll specifically discuss 2 that I think highlight some of the overarching challenges and lessons learned. So in the last presentation, Doug had referenced the randomized control of a biomass stove in Guatemala. As we learned from his talk, the contribution of community pollution may have masked some of the benefit of the intervention. But another issue is that these stoves still did pollute into the homes. So they weren't as low polluting as we would like to see. And I think one of the smart aspects of this trial is that it both measured exposure so that they could evaluate exposure response relationships as well as the intervention effect, and that's been very informative to policy. I also want to mention this trial in Malawi. So this is the largest trial that's been conducted, I think, to date. In it, the investigators enrolled over 10,000 homes in Malawi. And they also looked at the impacts of a biomass stove on childhood pneumonia. To avoid some of the community pollution issues that they had seen in Guatemala, the intervention was implemented in village clusters. And I think most concerning about this particular trial is that the stove actually led to a borderline significant increase in severe pneumonia in the intervention group. Data on air pollution weren't published with the results of the study, so it's not clear what actually happened to air pollution, but they did collect information on stove use in a subsample of homes, and I think that's quite interesting because it shows that not only were the intervention stoves not used very often, so by the second year, they were used for less than half of a cooking event per day on average in households. And they also broke quite a bit. So each intervention stove was broken on average 3 times during the course of the study. And these have been issues that have been sort of persistent across different intervention and trials that have been done. I think, at least in the field of household air pollution, we're starting to ask the question of whether or not it's really realistic to expect that a single stove can meet the diverse energy needs of households. So often trials are trialing a single stove, but obviously, people use different types of stoves for cooking different types of foods or for heating or for even lighting in some settings. So this figure is showing the number of cooking devices plotted against the total number of energy devices in Chinese homes. So these are data that were collected in 2017. And only 3 of the 856 homes had one energy device, and only 26 homes had 1 energy device, but then multiple other heating or lighting devices. So again, speaking to the fact that people are using lots of different stoves and stove types to meet their needs. So I think in theory, we are able to conduct randomized trials more easily in household air pollution than for outdoor air pollution, but they still have a number of limitations. Quasi-experimental approaches, I think, have been used less frequently in household air pollution than in the ambient air pollution or outdoor air pollution literature. Doug mentioned the coal ban, Dublin coal ban study, which is one example of a natural experiment. Another well-known natural experiment with household air pollution is one that used regression discontinuity to estimate the effect of a heating policy in China on air pollution and life expectancy. So on the left-hand side, so that line that is separating northern and southern China is known as the heating line. So above that line, heating is subsidized. So coal heating specifically is subsidized, and below the line, it's not. And so the researchers looked at both ambient PM10 levels, but then also life expectancy in people that were living just above that line versus those that were just below. And they found a 3-year difference in life expectancy between those with subsidized cold heating versus those without. Though in this particular study, they weren't able to control for other regional differences as they were in some of the studies that Doug was showing earlier. A study that we're currently involved in is evaluating the Beijing coal ban. So in this case, Beijing has designated coal restricted areas in 2017. And then they also started offering subsidized electric heat pumps and subsidized electricity. So in 2017, they required 2 million people to stop use of coal and then implemented the subsidy. And then they've expanded this now to potentially 63 million homes in northern China, where they have a stepped implementation over a 5-year period where they're implementing this program. One thing that we looked at in a cross-sectional evaluation, so this is a pilot study that we did, where we enrolled high income, middle income, and low income villages in 3 different parts of Beijing. And we found that while the high and middle income villages had nearly fully transitioned from coal to electricity, the low income villages, they were still using coal and really struggling with the cost of that transition. And I think these distributional effects of policies, they're really poorly understood. Often for trials and investigator intervention studies, they're often powered for, they're seldom powered for subgroup analysis. So we don't really have an idea of how these policies or how these interventions affect, for example, low-income households versus high-income households. And we also haven't done a very good job of evaluating whether or not there are detrimental effects of these policies. And I should mention that we have we're now doing a longitudinal evaluation of this program in about 1,000 homes in 50 villages. I think an exciting development over the past few years is that there now are an increasing number of national energy programs like the China coal ban. So they're all stepped in their implementation. So they do allow for quasi-experimental study. In addition to the study that I mentioned in China, in India, there's an ongoing program to provide free LPG connections for tens of millions of families. So switching gears a bit to big data, I think these large-scale programs are generating lots of new data on energy, and these can be leveraged by researchers. So this is an example of a study that was done by researchers at University of British Columbia, where they collected data on the sales of gas for homes that were both enrolled in an LPG, subsidized LPG program, and homes that weren't enrolled in the program. And they were able to evaluate use for those 2 different groups, finding that people that were in the subsidized program, they had increased their LPG use, but it certainly wasn't to the same amount as people that were already enrolled in the program. And I think that the question is whether or not it might be possible to leverage this type of data to evaluate space-time trends in energy use and outcomes, similar to the example that Doug had presented for the US, where it was looking at air pollution and life expectancy over time. So this is a crude example of work from the 1970s that evaluated changes in life expectancy that were associated with safe water programs in different cities in France. And I think one can imagine studies where we observe space-time changes in child mortality in places where the LPG program in India was implemented, for example. A number of researchers have started to explore the use of imagery data from satellites or from Google Street View for exposure assessment. It may be possible, for example, to use images that identify local sources of pollution, including stoves. So these are some examples from Accra and from Dhaka, and you can see that we're able to pick up some of the stoves that are used by households, at least outdoors in these images. That being said, it becomes really hard to identify a source that's primarily done inside the home. So in a study that we're working on in Accra for object detection, out of the 1,200 images that we were using, there were only 18 discernible stoves. So this is obviously a very small number for any kind of machine vision model. A number of studies have used large-scale implementation of small temperature sensors to measure stove use. So the idea is that there's a small button-sized temperature sensor that's placed on the surface of stoves. And the reason why this is done is because stove uptake and use has been historically a big problem or challenge in a lot of these intervention studies and trials. So trying to understand how households are using their stoves is beneficial for thinking about implementation of policies. So they collect long-term data on stove surface temperature, and then researchers have used machine learning techniques then to develop algorithms that can detect a rise in temperature that are associated with stove use events. So this is an example of work that was done by Ajay Palarasetti to identify stove use events for the HAPPEN trial, which is the large multi-country LPG stove trial. And then in that trial, they took it one step further. So they use this platform to identify intervention households that may not be compliant in using their LPG stoves, or maybe starting to use their traditional stoves. So the study team gets a weekly email on compliance so that flagged households that have been identified as potentially non-compliant can be visited by field staff who can then encourage compliance in the trial. I know a number of other people are going to be talking about low-cost air pollution monitors, so I'm not going to spend a lot of time on this, but I just want to note that these also have the potential for use in settings of household air pollution. But again, with the additional challenges like inconsistent or lack of electricity, the really high levels of humidity that we tend to see in a lot of developing country settings that we know are problematic for these sensors. And I think it's well recognized that calibration against a reference monitor is important for a lot of the low-cost sensors. And I think while many of us are fortunate to be in universities where there's a reference PM2.5 monitor at our university or even in our building, the majority of countries in sub-Saharan Africa don't have a single reference monitor available for use. So just to briefly summarize, I think there's relatively widespread agreement that actions to reduce household air pollution are very well warranted. These exposures are very high, and we have lots of evidence that air pollution is bad for health from lots of different studies in many different countries. But I think how to best improve air quality in settings of household air pollution is still a big question. I think there's some effort to move beyond the focus of a single stove and even maybe beyond household level interventions. And I think the increase in national or regional energy programs provide an opportunity to assess these more complex and realistic interventions. I think there's a big need to understand the distributional effects of these clean energy programs. We really know very little about how they impact the very poor in communities, whether or not they are able to afford the cost of a clean stove or the additional costs of a clean stove or clean fuel. And I think integration of social science research in conjunction with epidemiologic research is particularly helpful to try and address those questions. And then I guess just reiterating Doug's point around big data, I think there's lots of exciting developments and uses for big data and household air pollution, a lot of which are already being leveraged. But these are going to require lots of collaboration across multiple sectors and disciplines, and a really thoughtful study design. And with that, I will turn it over to the next speaker.
Thank you very much. This is Kiros Brahane. I'll have the privilege of introducing the next two speakers. The third speaker is Dr. Roger Peng from Johns Hopkins University, Bloomberg School of Public Health. He's a professor of biostatistics. He's a world-class expert on methods development in environmental biostatistics with focus on spatiotemporal data. He has made huge contributions in leading important applications to environmental health research with focus on health effects of air pollution and climate change. He's known for expertise in reproducibility research, very skilled in software development, and of course, many of you may know him from his podcasts on data science. Today, he's going to talk about opportunities for artificial intelligence and machine learning in environmental health. Roger?
Thank you, Kiros. I just want to double check that my audio is okay here.
Yeah, we can hear you.
Great. All right. Okay, so I just want to thank the first two speakers for some excellent presentations, and I just want to note that there's been a lot of discussion of study design in the first two presentations, and so I'll be shifting a little bit, talk a little bit more about kind of analytical approaches and techniques that may be kind of new and exciting approaches that we could use in environmental health. Of course, with the caveat that, and I think this has already been mentioned or at least implied, that no amount of fancy analytical techniques can substitute for solid study design and good measurement. So with that in mind, I think I'll talk a little bit about kind of what artificial intelligence and machine learning techniques might mean for environmental health going forward. So I think just to paint the very, very big picture, just to kind of make sure that everyone's on the same page and we have the same kind of context. The basic way that I see this issue is, so we have a dramatic increase in computing power attributable to something like Moore's law, and that has led to kind of two parallel developments. The first is what I would think of as big data, which is largely caused by kind of the improvement of measurement technology. And kind of in parallel to that is the increase in what I call algorithmic sophistication, which has led to a number of the kind of deployment of a number of different techniques that we might think of as artificial intelligence or machine learning. And of course, these two things interact with each other quite a bit. And the question that I want to address today is really kind of how do those two things, plus the field of environmental health and air pollution in particular, interact to create something new. And so I'll just give a little bit of background on kind of these ideas and some examples of how these things might come together and work. So on top of that, I wanted to mention that the National Academies, just a little under a year ago, had a 2-day workshop on the implications of artificial intelligence and machine learning in environmental health, generally speaking, so not just in air pollution, but although there was quite a bit of discussion of that topic. And then particularly they talked about various applications where AI and machine learning could have an impact, such as pollution source characterization. Exposure assessment was, of course, a big topic, and predicting chemical toxicity. There was also discussion of a number of challenges, such as data quality and uncertainty and transparency, reproducibility, that I'll touch on a little bit today, too. If you're interested in this workshop, there is a very nice summary on the National Academies website there. Some of the questions that were addressed in this 2-day workshop, which I think are relevant here, are kind of in general, how might AI techniques advance environmental health? How does AI change the standards or the approaches that are used for conducting environmental health research? And do they imply any change in our established kind of research principles? Some more ancillary questions are, how do training programs change to adapt to kind of these kinds of techniques? And whether there are any barriers to kind of academics who are working in this area in their institutions. And so I was on the organizing committee for this workshop, and along with many others around the community, and then we had a joint statement that we wrote at the end of this workshop that you can find at this last link here. My general thrust of this presentation is that I think there's a lot that we can bring over from the artificial intelligence and machine learning world, which has, for the most part, developed in kind of the computer science kind of fields, and has a huge kind of, shall I say, explosion of activity in really the commercial sector quite a bit. I think so in that sense, there's a lot that can translate over into kind of environmental health research. But with the caveat that we need to adapt these approaches to the specific needs of environmental health and air pollution research in particular, because the things that they do, for example, in the commercial world, in product development, are not the same things that we do when doing an air pollution study, when trying to assess the impact of changes in air pollution or changes in a policy on health outcomes. And so it's tempting to just kind of copy and paste over to air pollution research a lot of these fancy techniques, but I think some thought needs to be put into what are the needs of our particular field, and how can we adapt those approaches to meet those needs. And some issues that I think are worth thinking about right off the bat are first, transparency and reproducibility of these approaches, and then another one is how do we evaluate how do we do model evaluation with these kinds of methodologies in the context that matters for things like air pollution studies or other environmental studies. And lastly, how do we think about kind of building evidence for decision making in an air pollution context? A lot of these techniques are in artificial intelligence and machine learning are really designed for settings that are kind of an autonomous process. And so when we think of autonomous systems, we often think of either self-driving or self-flying or whatever, cars, things like that. But there's many areas where we might think of a system as being autonomous, where decisions are kind of made without any sort of human intervention or without frequent human intervention. And I think the decision-making process, at least in the air pollution context, is quite a bit different from that. It's not that we have machines making decisions about policies, but I think a lot of the output and evidence generated by these kinds of approaches would certainly fit into a larger framework about what kinds of evidence could be used for decision making. And so these particular tools could generate some powerful evidence for decision making, but would not necessarily be the decision making tools themselves. I'll talk about the other two topics also in a little bit later. One of the things that I think that has been touted as an advantage of artificial intelligence and machine learning techniques is kind of the ability to automate kind of lower level modeling decisions. So anytime we have an analysis or a data set and a question that we want to address, we often have to we often kind of try a bunch of different approaches and kind of see what works, and see what kind of produces the best or kind of the most interpretable results. And machine learning techniques have an ability to kind of automate that approach so that we don't have to make quite as many low-level decisions in the modeling process. And the idea to kind of being that we want to reserve kind of the higher level decisions for people or for humans in higher in the modeling process. But one of the issues that does come up is that the low-level decisions that you make, that these machine learning techniques make, can actually have a big impact on kind of downstream results. And so it's important to, even though we may not want to kind of fiddle around too much with these methods, it's important to know or to understand how these methods make these low-level decisions in the data. And the reality of these kinds of techniques is that they do require quite a bit of manual tuning. And so in some sense, the decisions that we traditionally made in data analysis kind of got pushed to other areas of the analytic kind of sequence, but that doesn't mean that they've all been eliminated. So that's kind of on the kind of some of the issues that we're going to talk about. I want to mention some of the measurement technologies that have kind of produced an explosion in big data. And one big one, of course, is wearables. And this has kind of both on the exposure side and also on the health side of the equation. Things like accelerometers, sleep tracking, heart rate monitors. There's a whole slew of wearable technologies kind of coming out on a very regular basis that allow us to kind of track various aspects of people, of their exposures, and things like that. And one of I think if there's a common element that brings a lot of these technologies together, it is their high frequency nature of measurement. And so they tend to measure data at pretty short intervals or a very high frequency, which results in a lot of data. Now, whether that amount of data is needed for a particular question. It is obviously depends on the question, but they tend to measure at very high frequencies and generate large data sets. Exposure monitoring obviously has changed a lot too. Has been an explosion of technology in that area too, with personal monitors, with low-cost sensors. There's also kind of crowdsourced monitoring with various commercial sensors. And these also tend to measure at a high frequency basis. And so you get a lot of time points and a lot of values there. But of course, as Jill mentioned in the previous presentation, there are issues in terms of calibration, in terms of their lifetime, in terms of their reliability of these kinds of monitors. In addition, we've had improvements in terms of GIS data, in remote sensing, satellite monitoring, these kinds of technologies. We have a lot more ability to not only image wide areas of, say, the United States or the world, but on a synoptic basis. So we got daily measurements, or sometimes twice daily measurements from things like satellites that are in kind of a sun-synchronous orbit. So that's a lot of kind of sensing data that can be integrated with things like low-cost sensors and whatnot. And so the general theme with all these technologies, I think, is an increase in the temporal frequency with which we measure the data. And some of them are either low cost, or because the remote sensing is so powerful, high resolution, we get a much higher spatial resolution too. So higher frequency and higher spatial resolution both lead to an explosion in kind of in the size of the data sets and in the detail that we have. I don't intend for this presentation to be a review of machine learning techniques, as that would be quite a substantial haul, but I just wanted to kind of highlight some of the generic features of these approaches. We tend to think of artificial intelligence and machine learning as kind of specific types of models, like neural networks or random forests or these kinds of things, support vector machines. Even linear regression might qualify as a machine learning technique. But the reality is that these techniques are coupled with many other steps that go into the ultimate outcome, which is a prediction. The first, of course, is the data processing and transformation and filtering. So what data points do we use? What gets included? Those kinds of decisions are made at a very low level, but can have an impact on kind of predictive ability of these approaches. The second step is very important in all methods, which is feature engineering or feature selection. And this, roughly speaking, comes down to selecting essentially what we might think of as predictors or the variables that go into the machine learning models. And so, for example, if you're looking at an image like a Google Street image or a satellite image, you might want to think of, well, which aspects of that image am I going to use for my prediction model? That kind of feature selection or feature engineering can be automated, but it often has a number of manual elements to it that humans kind of need to intervene on. After you've got the features and the data processing, there is a model building step where you have to build the model, you have to evaluate it, you have to split the data into testing and evaluation sets, and training sets too. And so that is part of the model building process. And then lastly, there's some out of sample prediction process where we kind of evaluate the performance of the final model on a performance metric of our choice. Something along the lines of a mean squared error or a area under the curve or R squared or things like that. So that's the general kind of sequence. Of course, there are many different kinds of approaches that can fit under such a generic framework, but those are some of the highlights. Some of the characteristics of machine learning approaches as opposed to more traditional analytic approaches is that most machine learning approaches really thrive on having large feature sets. So lots of variables, lots of predictors, and they thrive on these because they tend to penalize the weight that each one of these features gets. So they're not thrown off by things like multicollinearity or a high correlation between predictors like traditional methods such as as linear regression might be. And so that's one of the features of machine learning approaches. These approaches tend to be highly optimized to be fit to large data sets. So they're really designed to be fit to extremely large data sets. And this comes out of the kind of the commercial nature of a lot of these approaches where many large companies are dealing with data sets that are coming in on a very high frequency basis, and they need to fit these models very quickly to kind of respond or to make a decision in real time. And so as a result, we have access to a huge number of highly engineered platforms and libraries that can be used to fit these models. And for routine problems, they can be fit in very little, with relatively little work. Some of these libraries, like TensorFlow, PyTorch, Keras, allow you to kind of fit basic models with just a few kind of lines of code that can be executed at very large scale on very large data sets. And depending on the hardware that you have accessible to your analysis, you could be running this on large clusters of computers, on graphical processing units, things like that. So these highly engineered platforms reduce or almost eliminate the amount of kind of work that needs to be done to fit these complex approaches. So that's a huge advantage and a huge kind of contribution to the field that has been made mostly by kind of industry and kind of commercial participants. And then, so these machine learning approaches, one of the driving reasons to use them is that they leverage these large data sets to kind of capture various nonlinearities and complex interactions in an automatic way that we may not be able to pre-specify in advance if we don't know that they exist. And so in the event that we don't have particularly large data sets, it's often very difficult to observe such nonlinearities or complex interactions. And so therefore, on smaller data sets, these types of approaches tend not to offer a huge advantage over more traditional analytic models. Okay. So I wanted to give one example of the use of these kinds of approaches in exposure assessment, which I think is an area that has perhaps the most kind of potential for machine learning and artificial intelligence type techniques. This comes out of Scott Weichenthal's group, and he has a number of papers along these lines where they use satellite images to kind of complement the traditional use of things like land use regression models and GIS type data. And here they use convolutional neural networks to kind of analyze the satellite images to determine levels of particulate matter air pollution. And a couple of things I want to highlight about this particular approach. I think the use of satellite images is relevant because it does seem to appear that the convolutional networks or deep learning approaches are quite good at looking at image data. Image data has the advantage of being highly structured, it's highly regular, and it can be decomposed into different kind of scales of variation very easily. And so the images like satellite images or street view images can be broken down into different layers kind of in this convolutional neural network, and therefore a lot of kind of information can be extracted out of them. And so they use land use regression models to kind of predict levels or average levels of ambient PM. So we're not thinking over time at this moment. And then they complement that with satellite images and apply to kind of with convolutional neural networks applied to them in order to kind of expand the coverage of these land use regression models that don't have any GIS data available. And so their basic approach is to obtain the satellite images from Google Maps, which has satellite data. And then they train their convolutional neural network to the output from the land use regression. So it's worth bearing in mind that the land use regression output is considered to be kind of like the outcome, or is the truth, so to speak. And then they apply this neural network model to a larger region to get kind of a broader coverage. And so there is a bit of a trade-off that goes on here, which is that we can increase the coverage of our exposure assessment with the penalty of a little bit of decreased precision because the model is actually trained to the output of another model. So this is just one assessment that they present, comparing the land use regression model, so this is kind of the traditional approach, with the output from the convolutional neural network. And on the left, you can see the two cities, one in Montreal, one in Toronto. And you can see the kind of coherence or the kind of correspondence between the two approaches, the x-axis being the neural network and the y-axis being the land use regression or the traditional approach. So, so this assessment was done in an area where both techniques could be applied. So I want to bookmark this for a couple slides later, where I talk about how do we evaluate what the way that models perform and how they do things in the kind of traditionally in the AI and ML world, and how we might want to adapt that for air pollution research. And so this is a useful picture because it shows us kind of where or what levels the models do or do not correspond. But my general sense is that this could potentially hide some performance issues with these kinds of models because of the lack of any kind of spatial detail. So moving on from this, though, you can see this on the upper left, the orange region is the coverage for the land use regression model where there's GIS data available. And then the kind of red outlined regions is where the satellite data are able to cover. And so the point of this, of course, being that we want to expand the coverage of our exposure assessment. And so we can use the satellite data to kind of predict in areas where we have no GIS data. So that's on the left. And on the right, we have the predicted values from the convolutional neural network model based on the satellite data. And on the top, I believe, is Montreal, yes, and on the bottom is Toronto. So this is kind of the ultimate output from these kinds of models, which combines the GIS with the satellite coverage. Okay, so I mentioned a second ago in terms of model evaluation, and one of the things that I think needs to be thought about a little bit more carefully in this area is that air pollution and generally environmental health data tends to be measured over space and time. And I think that's although an obvious maybe kind of statement to make, it's relevant and I think shouldn't be ignored when applying artificial intelligence and machine learning techniques to this area. In many other contexts where AI and ML are used, there isn't necessarily a space-time kind of aspect. So for example, if you're measuring clicks on a website and you want to know whether this design is better than this other design, that's not quite exactly the same. There may be a temporal element there, but it may be ignored. And similarly, there's other contexts where machine learning and artificial intelligence techniques are used where we may not worry too much about the space or the time kind of nature of the data. But in air pollution studies, studies tend to either compare over space or they tend to compare over time. So if we're going to have an exposure assessment approach that is based on a machine learning model, we want to be able to, the bottom line I would say is that we want to evaluate the quality of that model based on the spatial and temporal needs of our air pollution studies. So for example, if I might crudely dichotomize the health effects that we tend to think of as either short-term or long-term, or perhaps short distance, I don't know, a short distance or long distance, then we want to make sure that the prediction models that we generate can accurately reconstruct the short and long timescales as well as the short and large kind of spatial scales. And so typically we don't focus on all of these spatial or temporal scales all at once. We either look at, say, acute effects for short-term or chronic effects for long-term. And so that's, I think, an important thing to recognize. We typically use global evaluation metrics with artificial intelligence and machine learning models, things like a cross-validated R-squared or a root mean squared error or area under the curve. These are global metrics that kind of provide an overall evaluation of a model, but they don't necessarily give a lot of detail into how the model is replicating specific spatial or temporal scales. And so these global metrics have the potential to hide kind of poor predictions or errors that only exist at specific temporal or spatial scales. And if we focus our analyses on those scales, then our model may seem better than it actually is. And I want to highlight one piece of work that was done by Brent Kuhl and a number of his colleagues, which is looking at the spatial scales of variation of particulate matter in the kind of Boston area. And they use wavelets to decompose the air pollution exposure concentration levels in this area. And they kind of dichotomize the exposures into kind of a low frequency or large scale spatial structure with a high frequency or high kind of short term or small scale spatial structure. So left is the low frequency, middle is high, and then the right is just the kind of global prediction that is made by the model. And so if we looked at just the right hand side, that's the output, that's the raw output from model. We don't necessarily know whether immediately whether the various kind of spatial elements are being reconstructed properly at the different frequencies. So being able to decompose that into the left-hand side and the middle is useful to see, okay, whether the large scale and the small scale structure is being replicated properly. And the reason why that's important is because the effects are different at these scales. So this is their result where they're looking at birth weight in the various trimesters. So I'll just focus on the first trimester just to save time. And you can see that they have different effects. The square on the very left is the kind of total PM effect. So just when you compare PM to birth weight. And on the right-hand side, you see that what happens when you decompose the pollution into the different scales. And so the large scale has a much bigger negative effect than the fine scale which has a smaller but still negative effect. And so the point here being that the different spatial scales have very different associations with the outcome that you're looking at, which is in this case birth weight. And so if you're focused on that particular scale, whether it's low or high, you want to make sure that a given model, a prediction model, can reproduce or can predict well the variation of the exposure in that kind of low or high range. Sorry, low or high frequency range, I should say. So the next thing I wanted to mention, I just mentioned model evaluation. The next issue is transparency and reproducibility. And this is, again, I think arises from the kind of the applications that have kind of driven a lot of the commercial applications of AI and ML techniques, which is that these techniques are quite complex. They involve a lot of parameters, and part of that is because they involve a lot of data. And I think the analogy that I like to use here comes from my colleague John Michel. He says, how would you evaluate a paper that ran logistic regression, which is a classical technique, but didn't publish any of the coefficients or the weights, right? So, and this is ironic because I think most of the time when in air pollution studies, if we do a logistic regression, the thing that we're actually interested in is the coefficients or the weights. So not publishing that would be like not publishing the results. But in many contexts where AI and ML methods are used, we don't care about the numeric values of these coefficients or these weights in these learning methods. We care about the predictive quality of the outcome and whether it's able to predict well in general in out of sample basis. So whether a given coefficient is 4.6 or 7.8 isn't really relevant in a lot of contexts, especially in the kind of commercial world. But and even in an air pollution study or in an environmental health context, even if the weights themselves are not particularly relevant or interpretable, there would still be a need to produce them or to disclose them for the sake of reproducibility and for the sake of kind of learning how these models work and how they can be kind of used in the future. And part of the issues is that even very minor variations in these kind of standardized machine learning platforms like TensorFlow or whatnot can be difficult to reproduce if you don't have the exact details. And so I think so there is a need to kind of figure out, well, what are the things, how do we communicate these model parameters, because they're so numerous and they're so kind of complicated. How do we communicate them in the way that others can kind of understand what is going on, but are not too much of a burden for the people producing the models? And one thing I just want to highlight here is that the reproducibility of the techniques or the models is not about ensuring that something is good or not. It's not a badge of quality. It's really about having it so that we can understand what is going on in the model, and if we wanted to apply this model in another context, we would know kind of how it was working here. And so I think in many senses, if you're doing product development, then what the customer cares about is that it works, but that's not really science. And so in the scientific context, we have to know how it works, and not that it works. And so that is the kind of one thing that I think needs to be adapted among other ideas in terms of the reproducibility and the transparency of these types of modeling approaches. So one quick example comes from was a paper in Nature where a couple of researchers at Google produced an artificial intelligence system for breast cancer screening. And in the paper itself, it says, the code used for training the model has a large number of dependencies on internal tooling, so internal to Google, that is, infrastructure and hardware, and its release is therefore not feasible. So the idea being here that there's a lot of what they've done was based on kind of code and libraries and perhaps hardware that are at Google, and they cannot be released for proprietary reasons, and for proprietary or trade secret type of reasons. And so, and I think so, a number of scientists in the genomics kind of area responded saying that this is really not acceptable, even with a kind of plain language or description. You can't reproduce these computational pipelines based on just like a textual description. And it's basically impossible to reproduce any of these results, no matter how good they might seem. And so these details include things like how I mentioned before in terms of how the data are transformed, how the features are engineered, what are the hyperparameters for defining the model structure, any sort of stochastic. So a lot of the elements of model fitting can be stochastic. And so if you run it twice, you don't get exactly the same thing. So how do these stochastic transformations work, and how can we reproduce them? Details about the fitting algorithms. So a lot of these gradient descent or stochastic data gradient descent algorithms have a lot of details, and a lot of tuning parameters that you can change to make them work better. So as you can see, this is just a hint or a smattering of all the little details that need to be kind of revealed in order to actually reproduce what someone's done. And on top of that, all that, this particular paper had some proprietary data sets that could not be released. So, and that's just a separate, the data sharing issues, I think, are a separate thing from the kind of analytic issues. So lastly, I just want
to interrupt. We need to be wrapping up. Can you jump to your conclusions, please?
Sure, no problem. Yeah, so I will just summarize. So I think my point is that a lot of these machine learning approaches are quite useful and and I think could be relevant in environmental health and air pollution studies, but we need to adapt them to the specific issues that are raised in our work, in particular things like transparency and reproducibility for the modeling, and how to kind of fit these approaches into the existing decision-making frameworks in air pollution or in environmental health settings. So thank you.
Thank you very much, Roger, for that very insightful and interesting presentation. By the way, I forgot to mention that Roger is actually a member of the HEI review committee as well. So last but not least, our speaker is going to be Dr. Neil Pearce from the London School of Hygiene and Tropical Medicine. And his talk is going to be entitled "The Big Deal About Big Data, Causal Inference, and Accountability Research, What's Next?" Dr. Pearce is professor in epidemiology and biostatistics, as well as professor of non-communicable disease epidemiology at the London School of Tropical Medicine and Health. He's a fellow of the Royal Society of New Zealand and the UK Academy of Medical Sciences. He's well known for his research on environmental science. His current research interests focus on epidemiological and biostatistical methods, and especially in their applications to studies of occupational and environmental health, including outcomes such as asthma, kidney disease, and neurological disease. Dr. Pearce?
Sure, thank you. Can you hear me okay?
Yes.
Yeah, and if I put the slideshow up, do you just see one slide or do you see more than one?
More than one right now.
Okay, so I've got a slight problem with my screen, so I'll just have to show the slides like this. I'll increase the size a little bit. Thank you very much for the invitation to speak. I think we're running out of time, so I've just cut a couple of my slides, but the main things I want to say are quite simple. What I'm going to talk about is a bit different than the other speakers, but it's very consistent with them. But I want to step back and look at the big picture of evaluating observational studies and evidence synthesis. And the main thing I want to say should be non-controversial, which is that when we evaluate a particular association, like does a pesticide cause a particular type of cancer, we need to consider all of the evidence, and that evidence synthesis always involves evaluating all of the evidence, rather than the alternative approach, which is to try and do one good study and focus on the findings of that study. So this is my rough schema of evidence synthesis. This is following what IARC does, where the International Agency for Research on Cancer, where it considers observational and randomized controlled trials in humans. It considers animal data and mechanistic data. And the human data may include systematic reviews, meta-analysis, triangulation, I'll talk about in a moment, and other types of evidence. And at the bottom, we have the individual studies. So the main point I want to get across is that evidence synthesis involves everything in this slide, and that we have to consider all of the evidence that relates to any of the boxes in this slide. These are Bradford Hill's viewpoints. I won't go through them all, but I will read this quote. He says, "What I do not believe, and this has been suggested, is that we can usefully lay down some hard and fast rules of evidence that must be obeyed before we can accept cause and effect. None of my 9 viewpoints can bring indisputable evidence for or against cause and effect, and none can be required. What they can do with greater or less strength is to help us to make up our minds on the fundamental question, is there any other way of explaining the set of facts before us? Is there any other answer equally or more likely than cause and effect?" So Bradford Hill's viewpoints were viewpoints. He made it very clear there were no rules for deciding whether a particular association was causal. Bradford Hill's paper was published in 1965. I still think there's nothing better. It's still the best foundation for assessing evidence. There have been a few developments since then, and I'll particularly give some examples of the idea of ruling out alternatives and the idea of triangulation. Both of them are consistent with Bradford Hill, but they really just take some of his viewpoints and develop them a bit further. So here's 3 quick examples that are relevant to these. First one is ruling out alternatives. When smoking and lung cancer was first discovered in 1931, but the first good evidence came along in the 1950s. And it was argued that the evidence might not be causal because there might be genes that caused people to smoke and also caused them to get lung cancer. And this idea that was put forward by Fisher, one of the leading statisticians in the century, people argued about it for 30 or 40 years. And it turns out he was partly correct, but only partly, not enough to explain the association. But the whole idea was refuted the moment it came out, because if there were genes that caused smoking and caused lung cancer, then lung cancer would always have been high in the population. But instead, what we see is lung cancer increasing as smoking increased. The point of this example is that time trends and ecologic studies are normally ranked very low in terms of causal inference, but this is an example, and there are many others, where they actually can play a crucial role. So if we had any sort of scoring system for epidemiologic evidence, we would probably throw away evidence on time trends, but actually it can be very important. This second example is actually from my PhD, which I did in the 1980s. I did a case control study of non-Hodgkin's lymphoma and pesticide exposure. And I had two control groups. One was a general population group, and one was a group of patients with other cancers. The argument for the general population group is that it represents the source population, but the concern was that if you compare people with cancer, non-Hodgkin's lymphoma, and you compare them to the general population, then people with cancer may have thought about their exposures more, and you may see a difference between the cases and controls just because of information bias. On the other hand, other cancers shouldn't have the same problem. They've gone through the same thought process. But on the other hand, you will get a bias if some of these other cancers are also caused by the pesticides that you're studying. Now, the point of these two control groups is that they are both biased, but they will produce biases in opposite directions. And in my particular study, you can see here, for example, this is 1.3 odds ratio using other cancer controls and 1.3 using general population controls. And incidentally, I can hear some background noise coming, someone talking in the background. So if it's possible to mute that, that would be good. Thank you. Okay, so these two control groups are both biased. So if you went through any sort of scoring system, you would say they were both wrong, but they're biased in opposite directions. So the fact that you get the same answers with both control groups is actually very reassuring. Final answer would be confounding by smoking in occupational studies. It's always raised as a potential confounder in lung cancer studies, but typically it's very small. You can see these are studies, either case control or cohort, which are either unadjusted or adjusted for smoking, and usually it makes no difference. What often happens when evaluating occupational studies is that the cohort studies don't have smoking data and they get rejected for that reason. The case control studies do get smoking data, but they're rejected because they are case control studies, and there is this myth that case control studies are inherently less valid, and therefore both types of evidence get thrown away. Whereas if you put together the evidence from cohort studies and from case control studies with smoking data, it's very consistent. So that brings me to the topic of algorithms and the false hierarchy of study designs. And there is still this attitude that randomized controlled trials are always going to be better than cohort studies, and they in turn are always going to be better than case control studies, and so on down the chain. Most of you won't recognize this, the picture at the bottom of this slide, but it's from English football, where the team I support, Chelsea, which is right at the top, was beaten by a team that was a long way below them in the various divisions. And the point is that on any given day, a very low-ranked team can actually beat a really top team. And also for a particular issue, sometimes a cohort study or a case control study will be better than a randomized controlled trial. And trying to draw general conclusions that one study design is better than the other is just not scientific. Here's an example from cardiovascular disease. We all know that if you want to prevent cardiovascular disease, you should smoke less, you should exercise more, eat less salt, you should drink less, and so on. These are all very well established, but this is the evidence from population-based intervention studies, and this is a Cochrane review, so it's the biggest and best evidence available. These are all studies where they had an intervention group for lifestyle and a comparison group with no intervention. If the intervention was successful, you would expect the effect estimate, this blue point, to be to the left of the line. This is what you get when you put all of the evidence together. And these are the biggest and best studies that show that things like cholesterol and smoking and so on are how they relate to heart disease. And basically, the intervention studies show no benefit, even though we know from hundreds of observational studies that these things are beneficial. And the main reason that the intervention studies show no benefit is that, well, many reasons, but the most common reason is there's not much difference between the two groups, that the intervention group, many of them don't follow the intervention, and the control group, many of them do. So you just can't get a very, very good contrast. A relevant paper with regards to air pollution. This is by Jennifer Peel, who's one of the chairs of this session. She asks, are randomized trials necessary to advance epidemiologic research on household air pollution? And she raises many of the same issues, that policymakers and funding agencies often call for more randomized trials, but they're not feasible for certain endpoints. They may not provide the necessary information, and they may even lead to improper causal inference. And here are some of the problems. They're not good for long latency or rare diseases. You can use biomarkers for early effects, but the relevance is usually unclear. Very difficult to blind participants or investigators. These are the two problems I just mentioned: low adoption of intervention and spillover effects. There are ethical considerations. There are many problems with RCTs for air pollution. So what we really need, as Jennifer recommends, is a variety of study designs, both observational and randomized, including a variety of research approaches. So what we're dealing with here is really a very old debate. I've been doing epidemiology for 40 years now, and the whole time there's always been this message that you can only prove causality for randomized controlled trials. It's not true. We have proved that smoking causes lung cancer beyond reasonable doubt. We've proved that asbestos causes lung cancer. We've discovered many things and established causality. without doing randomized controlled trials for any of them, because to do randomized controlled trials would be impractical or unethical. The debate's now in a new form, namely that we can only establish causality with randomized controlled trials or observational studies which are analysed using modern causal inference methods so that they look very much like randomized controlled trials. And this is the basis for these algorithms, which unfortunately are becoming very influential. There's GRADE, which was originally developed for randomized trials, but is now being applied to observational studies. There's Robbins, which is a tool for assessing risk of bias in non-randomized studies of interventions. These would be the main two, but there's many more. I sit on many advisory and regulatory committees, and there is constant pressure to use these particular algorithms to decide on the evidence. Why is it a problem? Basically, it's a rerun of the old debate that you can only establish causality with randomized controlled trials. It suggests that causality can be established with a single perfect study, and we should always strive to do such a study rather than taking a more comprehensive triangulation approach. Couple of recent examples. One many of you will be aware of is the controversy over red meat. Now, I'm not a great fan of nutritional epidemiology. I think it's difficult to do, and it often gets findings that are wrong or modified over time. Nevertheless, this controversy is a good example of the misuse of algorithms which see the randomized controlled trial as the gold standard. This was a review, IARC reviewed all the evidence for red meat. There were some randomized controlled trials, but not very good ones. They were not interventions specifically on red meat. They didn't follow people for very long. There was a lot of observational studies. There was good evidence from animals, and I put it all together and came to a conclusion about the carcinogenicity of red meat. What this review did was basically use GRADE and scored the observational studies and decided that none of them were any good and threw them all out, and simply used a couple of intervention studies which were not really relevant and used that to decide that there was no firm evidence that red meat caused a health risk. And unfortunately, this approach is becoming more common. This is a quote from the New England Journal of Medicine just a few months ago. Rather than relying on the weight of evidence approach that EPA has traditionally used to infer causation, the Clean Air Science Advisory Committee wants to rely on studies that use manipulative causality. This theory restricts epidemiologic evidence that may be considered acceptable to assess causality to results from intervention studies or studies that have been analysed with the use of causal inference statistical methods. And unfortunately, I think we have a sort of perfect storm now. There's various vested interests, and that can include industry, it can include environmental groups. There's lots of pressure on regulatory agencies, and there's a natural tendency to want to have a good paper trail and to show how decisions were made. And therefore there's pressure to adopt a tick box approach. And from causal inference theory, there's a similar pressure that only RCTs or RCT type observational studies can be used to establish causation. And this is creating major problems, because if you follow that paradigm, we end up throwing a lot of good evidence away, and therefore we can come to wrong decisions. So what should we do? Two very good papers I'll refer you to. One is on the whole idea of triangulation, done by Deborah Lawler and other people in Bristol. Triangulation is the practice of obtaining more reliable answers to research questions through integrating results from several different approaches, where each approach has different key sources of potential bias that are unrelated to each other. We emphasize the importance of being explicit about the expected direction of bias with each approach whenever this is possible, and seeking to identify approaches that would be expected to bias the true causal effect in different directions. And the second paper by David Savitz, who of course is heavily involved with HEI, he basically makes the same criticisms I do about the problems with mechanistic risk of bias assessments. And he argues that instead, risk of bias assessments should focus on identifying a small number of the most likely influential sources of bias, classifying each specific study based on how effectively it has addressed each potential bias, and determining whether results differ across studies in relation to susceptibility to each hypothesized source of bias. So I think what's happening now in a lot of regulatory and policy committees is that you start with all the individual studies and you score them using something like Grade or Robbins, and most of them get thrown away. And then only the studies that score well are actually assessed in terms of causal inference. And as in the red meat example, you're not left with very much. So you end up throwing away a lot of good evidence, which may not be perfect on itself, but may address one particular issue and may contribute to triangulation. What we need to do, consistent with David Savitz's paper, is turn this around. Start by looking at all of the evidence and then say, what are the potential biases? So for example, if you're looking at air pollution and lung cancer, or occupational exposures and lung cancer, you might be concerned about confounding by smoking. And then you look at subgroups of studies, some of which have very good smoking data, some of which have not such good smoking data, and some of which have no smoking data. And the ones that have smoking data, did adjusting for smoking make a difference? If it didn't, and if the findings are the same as in the studies which don't have smoking data, then you can be much more confident about the findings. Like I said, other evidence, including evidence on time trends and population patterns, may be important. You can look at different populations where the biases would be different or in different directions. You can look at animal studies, you can look at mechanisms. You need to consider all of the evidence. And I think we're sort of stumbling into a situation where many policy committees, all they do is use these checklists like Grade and Robbins. They throw away most of the evidence, and what they're left with is not very convincing, so they conclude that there's no evidence of causality. Doesn't mean that all the evidence is the same. Some is much better than others, but you have to look at it in context and consider it all together. So I've rushed through that a little bit because I wanted to make sure we have time for questions and discussion. But that's my main message, that causal inference and evidence synthesis is not just a particular set of techniques, and it's unfortunate that the name causal inference has really been captured by a particular approach to data analysis. Causal inference involves looking at all of the evidence, and sometimes you will have very good RCT evidence, often you won't. And whether you do or you don't, you need to consider also the evidence from animal studies, from mechanistic studies, and adopt a triangulation approach to looking at the evidence from observational studies. Okay, thank you.
Thank you very much, Neil, for that excellent and thought-provoking presentation. At this point, I would also like to thank all our 4 distinguished speakers. I'm sure you join me in, in saying that, those were really excellent and thought-provoking presentation as a whole. At this point, what we're going to do is go to the question and answer session. And the panelists have agreed to be available a few more minutes, so we might have a little bit more time. Thanks to all of you who submitted questions. So what we're going to do is kick off, the session with 2 questions. I'm going to pose the first one, and my co-chair Jennifer Peel is going to pose the other one. And I'm going to try to fold in some of the audience questions into what I'm going to put out to the speakers. So the first question is, given that all the potential of big data and machine learning techniques, what are the pitfalls that we need to guard against when using AI or ML approach in accountability research and causal inference, especially in the big data context? And I would like you to frame your answers to, in relation to relative value of bias versus inference, role of designs, and some of you have touched on already, increase in volume of data versus relative increase in signal versus noise, especially because environmental health signals are generally small. And 3 questions from the audience actually fit into this. One was by Sverre Vedal, especially focusing on this issue of propensity score matching in the big data context, and whether the lack of individual level matching actually could harm or how it can be handled, and also the overall quality of data in the big data setting. Then there was another question by Ayoung Jeong, again, dealing with issue of using big data that are dirty or messy and data that are not ready. And a related one was from Kwaku Poku-Asante on the potential of AI and ML data, especially in the context of LMIC and Africa, in relation to quality of data and availability of data. So maybe we can kick off with Roger, since he gave the technical presentation, but any of the speakers could chime in.
Sure. Yeah. I'll try to address that massive question.
Sorry about that.
Well, I think the question itself kind of presumes that we can answer it. And I think one of the things that I think is interesting about AI and ML in this area is that it's still, I think, relatively early on. And I think the biggest pitfall that we want to avoid is introducing any sort of false dichotomy between, say, analytical approaches and things like study design and measurement, exposure measurement quality. We can't look at that as a trade-off. Because we have to continue to kind of have strong study design, strong questions, and strong measurement in addition to using these kinds of approaches. So that's number one. And I think the other thing I wanted to mention is that there's a lot of these techniques have been very successful in kind of what I would think of as somewhat specific settings and very kind of highly kind of engineering types of settings. And when they have been broadened out to more kind of real world, or say perhaps different types of settings, especially in scientific contexts, they haven't necessarily been demonstrated to show dramatic benefits over, say, more traditional approaches. And I think, so that's something I think we need to kind of be careful not to just assume that these will be better or that they will be provide better or more information than other approaches. So.
Could I chip in? Neil Pierce here. Big data is good for prediction. It's not good for causal inference. It's very good for your supermarket to know, what you would like to buy next week and send you some advertisements or some coupons. But it's very difficult to use for causal inference unless you have biological knowledge. To give one example, if I have a big data set on lifestyle, I might find that if someone is a smoker, that predicts their lung cancer risk. I also might find if they use a cigarette lighter every day, that also predicts their lung cancer risk very well. One of those is causal, one is just associational, but any big data analysis will probably pick out both of them as being important. And that's fine for prediction, but suppose I want to intervene and I ban cigarette lighters, it's not going to work because it's not a causal association. And that is something you can't tell from the data. You need biological knowledge to know that smoking is a causal risk factor and using a cigarette lighter is not. So there are some uses in causal inference, but they're very limited. It's mostly good for prediction. And that's why I think it's good for one of the examples Roger showed, that you can use it to estimate people's exposure, because it really doesn't matter if the predictors of exposure are causal or not.
Thank you. Anything more to add, Doug or Jill?
No, I think the first two responses are great. I guess the only thing that I'd add in sort of the low-income setting perspective, which is that I think it's quite tempting, or it's been quite tempting in sort of big data and data science to say, hey, there's lots of places where we don't have measurements. This is going to be great. This is going to solve all of our problems. And in a lot of cases, I think it's just not clear what we're measuring. And it becomes really hard to test that in a very detailed and robust way. And so that certainly presents a challenge, is if we're going to try and develop these data sources for low and middle income countries, there needs to be lots and lots of upfront work done in advance in trying to use these, and particularly if you're using them in epidemiological studies or policy evaluations.
Thank you. All right, Doug, anything to add? Yeah, go ahead, please.
Yes, on this issue of the propensity scores, and I think it's an interesting perspective to think about how we can use the big data to actually be matching people for interventions versus non-interventions. And I'm not sure propensity scores are the best method here, but it certainly points us in a direction that we can think of new ways to use these data and to be actually drilling down to get better matching. And, you know, I think there's great potential here.
Maybe if I could respond to that, because I really liked Doug's talk, except for this bit about matching, because it's a nice idea, but I don't think it's as useful as some people think. If you have a very large data set and you adjust for age, sex and race, and then you created a subset where you actually match exposed and non-exposed by age, sex and race, you will get exactly the same answer. In fact, a larger data set will be a bit better because it has more people in it. So it's a nice conceptual thing, because it's once again, it's based on this RCT paradigm that you're setting it up as if you're doing an RCT, but whether you match on 3 or 4 variables or adjust for them, you'll get the same answer and you'll have the same problems of residual confounding as the full observational study. So I think it's a nice idea, but I don't think it's a solution.
Neil, I think you're right about that, that it really is just an alternative way of approaching this, and actually consistent with your perspective of, you know, using alternative approaches, looking for the consistency. I think this is another opportunity to take advantage of that.
Yeah, I agree. No, I think it's a nice idea.
Thank you all for those interesting answers. So Jennifer, if you could go on with the next question.
Okay, so we had some interest in exploring this idea about taking advantage of the current situation with the COVID-19 pandemic. So I'll address this first to Doug, and then others can join in as well. So what are opportunities for accountability research in light of the COVID-19 pandemic, especially with respect to big data and the decline in pollution and new health-related complexities? And also, are there potential confounding factors in this question that would be a barrier for the research?
So, yeah, as you know, we're thinking about this. I mean, obviously, reading the newspapers, you see that we have a unique situation here where air pollution, traffic, many things have changed. And to be creative and think about what the opportunities are, you know, we'll have to see how this develops, but clearly there are huge confounders, other things going on that are going to have to be need to be considered. But gosh, to think about this as an opportunity, and I mean, we never should be held back by the fact that you can't, somebody saying you can't do this because you haven't thought about all the factors. I mean, there clearly are some really interesting things out there that in the future, when we start gathering the data, would be potentially interesting. I mean, we've danced around this question of what is the impact of living near a heavily trafficked road, for example. And now we have the opportunity of looking at what's happened if you remove all the traffic over a period of time. How does that affect people living nearby? There's, I think, some really interesting opportunities here for creative young scientists to look at. I'm just very excited about, well, I'm not excited about the coronavirus, but I'm excited about what this presents as an opportunity.
Absolutely. Any of the other panelists want to chime in here?
Yeah, sure. 2 things. I agree completely with Doug. It's a huge opportunity, particularly to look at air pollution, and he would know a lot better than me what could be done, but there is great potential there. Secondly, whatever's done is not going to look like the study designs we are taught in Epidemiology 101, and it's not going to look like an RCT. And I think the whole issue of COVID shows it's really a condensed version of what happens with any sort of evidence synthesis. You know, if you're looking at air pollution or pesticides or something, you might spend 20 or 30 years, but ultimately you still have to make decisions on the basis of imperfect evidence, and you normally don't have RCTs. Here it's happening with COVID, but it's happening in a few weeks, so people have to make decisions about whether to lock down New York or not. But you can't do an RCT. You can't lock down New York and not lock down Chicago. But you do have natural experiments, and you have all sorts of evidence, and that it's like a condensed version of what happens in any evidence synthesis, that ultimately you have to make decisions based on a whole variety of evidence, none of which is perfect.
I have to agree with Neil very strongly here that this is not going to be the same type of studies we've done in the past. And it's really interesting that the people in the administration who've rejected science before because, well, for many of the reasons Neil had elucidated in his talk, requiring RCTs, for example, now are basing decisions based on anecdotal evidence. I mean, it's really an extraordinary situation for how decisions are actually made in a volatile situation without much real scientific evidence.
Just from a household air pollution standpoint, one thing that I did want to mention is, I think while we're seeing these reductions in lots of places due to changes and reductions in traffic and in China industrial emissions, I think it's possible that in a lot of places where household air pollution is an issue, we could actually see higher exposures. So people are inside more. We know that people, at least anecdotally, are cooking more. They're using their stove more. They're seeking sort of comforts that might be associated with warmer temperatures inside of the home, which would be associated with increases in uses of fireplaces and other types of heating stoves. So I think that, certainly lots of people have, including the ongoing trial that's happening right now, there's lots of places that are measuring long-term indoor concentrations and exposures in these settings, and it'll be interesting to see how that plays out. And it might be quite different from urban areas.
Okay, thanks. So there is actually a follow-up question that goes with the first one I asked from Chad Bailey, probably with Roger as a first responder. How much has been done to evaluate the use of AI and machine learning methods to make noisy measurements more precise? And what are the metrics for evaluating such efforts? If you could answer to that one. And I think the question was in the context of complex ML models with many low-cost air pollution sensors as an example.
I think this is, I mean, with the caveat that this is just my personal exposure to this area, but I think there is a lot of work that needs to be done in terms of developing algorithms and approaches to calibrating these types of things, especially in kind of a real-time setting, because I think it's not immediately clear. Given this, if you have multiple monitors with, say, like a single reference monitor, or if you have multiple reference monitors, how you kind of calibrate them and how you adjust them in real time, because the low-cost sensors tend to drift and they tend to move around, so things can change in a dynamic setting. So I think there is quite a bit of work that still needs to be done to kind of address the measurements in those kinds of settings and kind of to improve them.
We had Sorry, Kuros.
No, go ahead, please.
We had another question this one is directed to Neil. Several excellent epidemiologists and also the members of the committee for the revision of the WHO, air quality guidelines try to produce more papers with causal analyses and risk of bias tolls for observational studies as a response to the critique that we do not have enough RCTs, instead of coming out to say that these procedures are not always appropriate for environmental health studies. Would you advise taking the second line, in other words, coming out and talk about the principles of research?
I haven't read those reports, but I've heard quite a lot about them, and I know there's been a lot of debate about them, so I can't comment on the reports in general, but my impression is that they make the same mistakes as the red meat example I gave, where they end up throwing away a lot of good evidence or scoring it very, very low, because the RCT paradigm is really held up as the gold standard. But I can't comment on them in more detail than that. And I would say that I've worked with a lot of people trying to think about these methods and think about the problems of using grade and Robbins for evaluating observational studies, and much of the motivation comes from some of the things that have happened from applying grade to air pollution.
Jennifer, if I could comment on, I mean, you know, in air pollution, we have a very well-developed body of literature. And so it's possible to, in fact, extend to these other types of analyses. And it's been very helpful to see that, as Neil indicated, it really doesn't make any difference how you analyze these data. On the other hand, where we have newly developed environmental hazards and the literature is very thin, you know, I think that's where the risk is, that, you know, using these approaches and where you have much less data is going to allow or really hamper our ability to make decisions and provide the information for policy decisions. So I'm more concerned about the application of these approaches that Neil describes in other environmental hazards, especially the new hazards coming on screen.
Thanks all for your comments. Anamoon, do you want to end our session?
Yes, I'd like to really thank all the speakers and chairs and all of you participants who have hung in there until the end. With apologies for running over time a little bit, but this has been a very stimulating session and discussion with lots of questions generated that we'd be happy to pursue in the coming weeks and discuss further with any of you who want to contact us and continue the discussion about these important topics. I'd also like to thank the HEI sponsors who have continued to support our mission and throughout the accountability work that we've done and other work that we're doing. And finally, let me just say we look forward to seeing you at the next webinar on particle components and associated health effects on April 29. We'll have a sign up for you very soon. We also would really like your feedback on this first webinar in our series. I think there was a great kickoff, and we look forward to seeing you at the next one. Thank you very much.